Depression Center, and today we have Dr. Berman who will be speaking, and then we have some panelists afterwards. So he'll be giving a brief presentation, and then you'll get the opportunity to hear from our panelists and ask questions. So you all have note cards on your chairs. So if you want to write your questions down, then we will come around and collect them, and we'll give them to the panelists so they can address your questions. If you need pencils, I'll be around with pencils as well too. And if you wouldn't mind filling out the evaluation at the end. So thank you very much.
This is the one I can use if I want to walk around. Okay, all right. Well, welcome everybody. Let me just tell you a little bit about myself and the work I do before I talk about depression. And I made the decision not to do a PowerPoint. I just want to talk off the cuff, and I think that's a lot more personal. Feel free to raise your hand and ask questions as we go along. My goal tonight will be to share some thoughts about depression, the prevalence, the impacts, how we diagnose it, what are some of the common treatments, what are some of the challenges and struggles that people experience and families experience and clinicians who treat depression experience. So let me just start by telling you a little bit about myself. My name is Ben Berman, and I am by training a child and adolescent psychiatrist. But that doesn't mean I only work with children and adolescents. Every child and adolescent psychiatrist is also a general psychiatrist who completes a fellowship in child and adolescent psychiatry. So I work with patients across the age span, not so much with the geriatric population, but with children and adolescents, with young adults, with other adults, and do a lot of, my main job at the university is I'm the medical director of the inpatient service. So the child and adolescent inpatient service is where patients who are receiving inpatient treatment, typically they're in some sort of crisis or really struggling, stay for a period of time where we try to diagnose them and provide some treatment and facilitate their transition back into the community. The other work I do is in the substance abuse clinic, so the University of Michigan Addiction Treatment Services. And there I work mainly with the adolescents, so kids who come in who have difficulties with drugs and alcohol, smoke marijuana, have some sort of substance abuse issue, in addition to some underlying psychiatric issues. Okay, so that's a little bit of my background. I'm originally from Michigan, did my training at the University of Pittsburgh, and then I'm on faculty at the University of Michigan for the past 6 years. So I would start by saying, life is hard and life is challenging. We all face stressors, we have a lot of responsibilities, we have relationships in our life. There are a lot of things that are tremendously stressful to people, and that can cause some difficulties. And most people can roll with the punches and have ups and downs. But some people, a fair number of people in society, experience depression and have a more difficult time handling the ups and downs. The first thing I would say about depression, and I'm sure you all know this, is that it absolutely does not discriminate. So depression is an illness that can affect people at any stage of their life, at any time, during the most successful period of their life, during the most productive time of their life, in addition to times in their life that aren't going so well. A lot of times when we think of people getting depressed, we try to look for an underlying cause or something going on in their life that's stressful or causing them to feel depressed. And in fact, many times there is something. So a loss or some sort of crisis, something going on. But a lot of time there really is not an identifiable stressor. So that depression can just strike somebody in the prime of their life at any age, at any time. And so it absolutely does not discriminate. It doesn't discriminate against, in terms of economic success or work success, professional success. It can strike anybody at any time. So that's something that is very important to remember. The other thing to remember about depression is that depression has a lot of different forms or different types of depression. So depression for one person may not be the same illness in another person. Okay, so typically when we think of depression, we think of an individual who is sad, down, blue, not enjoying life, their mood is low, and they're not functioning at their capacity. Something is wrong, and at the same time their mood is very negative and very low. And that can come in various forms. So the classic kind of depression that we see and many times people are hospitalized for or seek treatment for is what we call major depressive disorder. Okay, so major depressive disorder is an illness where the individual has mood symptoms, so their mood is low, they're feeling down, they're feeling sad, feeling blue, or feeling irritable, grumpy, grouchy, not themselves, or having difficulty enjoying things, things aren't pleasurable, just they've lost their zest for life, and that's a change from their functioning. So in addition to having a low mood, individuals with major depressive disorder tend to have some physical symptoms that go along with it. So difficulty sleeping or wanting to sleep all the time, changes in appetite, changes in energy level. It's a very physiologic kind of illness. So you have that combination of low mood plus some physical symptoms. And then many patients have thoughts about suicide or wishing they would die, just wanting to escape from this very difficult time they're going through. And it's not something that passes overnight. It's not something that people can snap out of. It's not necessarily associated with something negative in the person's life, not a reaction to a life event. It's an illness that occurs, it has a biologic basis, and runs in families, and so on. So that's classic major depression. Anytime somebody is depressed, you have to consider whether they have bipolar disorder. Okay, so just because somebody is depressed doesn't mean that their diagnosis is major depression. So there are people that swing to the other extreme and have periods, mood episodes, where their mood is actually better than good, too good. So a manic episode is an episode where people might not need to sleep as much, might have excess energy, be reckless, make decisions that they wouldn't normally make, like spending a lot of money, doing things that are more reckless and out of character for that person. And when you combine that manic state, times where people are manic, with the depressed phase, that's bipolar disorder, okay? There are other types of depression that are more characterologic. So there's something called dysthymic disorder, where somebody doesn't have a major depressive illness. They don't have this period of time where they have physical symptoms and mental symptoms, but they're just sort of down in kind of a low-level depression. They might work, have a family, do all, just kind of, you might not even know they were depressed, but there's a down element to their mood, a sadness, and maybe some of those physical symptoms. And dysthymic disorder tends to last for a long time. So in order to give somebody that diagnosis, for example, we want to see those symptoms for a couple of years, not just 2 weeks or 3 weeks, okay? There is depression associated with substance abuse. So people who abuse substances, alcoholism, other drug addictions and substance use can cause symptoms of depression. Medical illnesses can cause symptoms of depression. So certain types of cancers or other physical illnesses can have depressive symptoms. And then there are what we call adjustment disorders. So somebody has an event in their life, some sort of crisis, something that happens, and they become depressed, okay? And I mentioned to you that you don't have to have some sort of a negative trigger in order to become depressed, but that does in fact occur for some people. And if it weren't for that negative event, the person might not be depressed. So somebody going through a divorce, I work with teenagers, so they go through a breakup, don't get a homecoming date, get their first, non-A in a class, that can be a major crisis for somebody who doesn't have the good coping skills. So that can throw somebody into a depression. And so the bottom line with this is that there are various types of depressions. They come in different flavors, different types of depression, and the different types of depression require different types of treatment. So it's not always a simple thing to diagnose. Finally, I would say that depression is sometimes associated with other illnesses at the same time. So it's not uncommon to see somebody with depression who also struggles with a lot of anxiety. So depression plus anxiety. Or somebody who has depression that also struggles with a medical illness. Or somebody who has depression who also has a substance abuse problem and they're self-medicating. And so we call that dual diagnosis. So it's, the depression is made worse and exacerbated by a second illness or a third illness that goes along with it. So one last thought about the forms of depression is sometimes tricky to diagnose. Sometimes we don't know the person is depressed, or they don't realize they're depressed. For example, teenagers can be very moody. That's kind of a normal state of affairs for a teenager. Their hormones are changing, all kinds of things are going on. And so it might be difficult to recognize what's normal and what is depression based on behavior changes or those kinds of things. So it's important to keep our eyes and ears open. In adults, many times they have various aches and pains, something going on physiologic, something physical, just not feeling themselves, having low energy. They might have repeat visits to the doctor, get their thyroid checked and all kinds of things, all the lab work is normal. And you ask, how's your mood? And, it turns out that the person has some depression. In elderly folks, sometimes they might have memory problems or some cognitive problems, and it looks like they have Alzheimer's or a type of dementia. And that's common in the elderly. However, sometimes that is depression, and so it's important to recognize there are different things at various stages in life that make people vulnerable to becoming depressed. And in the later years of our life, people tend to face a lot of losses, the death of a spouse, lost productivity, that they might not be working, might struggle being retired, not be able to get around as much, and that's a setup for depression to occur. So it's important to look across the age span and look at the kinds of things that are going on in people's lives that might cause them to become depressed. Depression has a high morbidity and mortality. Okay, so untreated depression, the worst outcome is the fatality. So depression, as we know, can be associated with suicide or other kinds of dangerous behaviors that place the person at risk. But aside from that, a lot of people don't realize that depression is the #1 cause of disability in the United States. So higher than any other major illness, including heart disease or any other illness. When you look at people on disability, depression and some other mental disorders are the top causes of disability, with depression leading the pack. That's true, that tends to be true worldwide when you look at decreased productivity. So depression is, especially untreated depression, really takes its toll on society. People aren't as productive, miss days of work, can't function as well. And so it has a lot of, I'm always amazed at the number of healthcare dollars we spend on other illnesses and the amount of attention that we pay to other illnesses. Not to say that those aren't important, but the #1 cause of disability in the United States is depression. yet what percentage of our healthcare dollars are spent on the treatments or making services available? It's something that we struggle with. So it definitely has a high morbidity and mortality, and a lot of human suffering. So the individuals who are depressed aren't enjoying their life. They feel down, they feel blue, they feel sad, and a lot of times they don't realize that help is available. It can affect families, relationships, and so on, in a very, very negative way. So the good news is that depression is very treatable. Okay, we have good treatments for depression. One of the difficult things about depression, a couple things that make it difficult to treat. Number one, people don't always come forward when they're depressed. So, as I said, it's sometimes tricky to diagnose, and many times people don't recognize that they themselves have depression. So the person who makes repeat visits to the doctor because they have physical aches and pains, and you ask them how their mood is and they might be depressed, some people are actually offended by that or feel like they're being criticized. Part of the illness of depression is that people feel ashamed, and you can struggle with self-esteem and feel down and feel blue. And people also feel ashamed about having the illness. So that can be an impediment for people seeking care. And I find this is particularly true among men. So, men in our society are the breadwinners. They're supposed to be productive, function well, not be sad, not show weakness. And when men have depression, a lot of times they feel like it's a character flaw, it's a personal weakness, something is wrong with their character. When in fact they have a treatable illness and can get better and do well and not have to struggle with it. So it tends to be stigmatized, not only by society but by the individuals themselves who have the illness. And some of that can be because of the illness, because people with who are depressed tend to have very negative, self-denigrating kinds of thoughts, even about their own illness. So we can't always get people to treatment. The other big factor is availability of treatments. So in mental health, in psychiatry, a lot of times we do battle with insurance companies to get people access to treatments. This is changing, finally, but a lot of insurance policies carve out mental health benefits. So whereas your medical benefits are unlimited, you can have as many days in the hospital as you need, or you can have as much chemotherapy, they might limit somebody to 20 therapy sessions per year, or limit the number of days the person has to be in the hospital. The thing that I battle as an inpatient doctor is, let's say somebody was suicidal yesterday and got admitted. 2 days from now, they're feeling a little bit better. They're still at risk, but they're not saying they're going to go home and kill themselves. The insurance company might deny further stay in the hospital before the person is well. So it's a reality of how we provide coverage. The third thing is, I think as a society this is changing, but there still is a stigma. I want to share one point of view, and I don't want to offend anybody, but I just want to share my feelings about something that happened in a local community in Ann Arbor, and some of you may know the individuals involved, but I just want to share my view on something. So there was an editorial that was written in the New York Times by 2 high school students. They went to community high school. And those 2 students decided that they wanted to devote an edition of the school newspaper to depression. And so they decided they would interview students who had experienced depression. They got permission from them, and they got permission from their parents. And these students wanted to talk about depression. And they wanted to have an edition of the school newspaper devoted to depression. And some administrators felt that this was not a good idea, because what if those students later on regret that they had come forward and said they had depression? And so those 2 students who headed up the project wrote an editorial in the New York Times and described their experience. Because my reaction was, so what if they said they had depression? To deny them the opportunity to kind of voice their, talk about it, further stigmatizes the illness. And I wanted to say, shame on us as a community for not allowing that. Because I think messages like that can be stigmatizing and set up, make it more difficult for people to come forward for treatment. Okay, so that's my view on stigma, and I'm sticking with it. So I think depression is an illness like anything else. So what if you're depressed? Come forward, get treatment. It's common. Treatments work. Welcome to the clinic. Welcome to the hospital. We want to help you. Okay, so that's the message that I would give to people. There's no need to be ashamed or hide under a rock. Get the treatment that you need, or encourage your family member to get the treatment, because we can help. So just a couple words about treatment, and then I'll see if there are any questions, and I'll let the panel discuss or share some of their thoughts. So depression is very treatable. The various types of treatment we use. One is medication. Okay, so not everybody who's depressed ends up on medication. But antidepressant medication and other types of medication can be very helpful, very life-saving, really make a huge impact on the person's life, improve their mood, improve their sleep, their appetite, their energy, and really work wonders. Okay, so there are good medications out there that are very effective and can effectively treat medication. A couple things about medication. One, it's not the only treatment available. So by itself, for many people, medication is not the only answer. There are some other treatments that need to be used. Secondly, medications have to be used effectively. So it's very important for the person to be on the right medication at the right dose for the right amount of time and stay with their medication. A lot of people begin to feel better and stop their medication prematurely. And so it's just like with an antibiotic. The doctor always says, even if you feel better in 2 days, take the entire 10 days of your antibiotic, because if your infection comes back, it's a lot more difficult to treat. A lot of people who get relief from their symptoms stop their medication, and so the depression comes back and it makes it more difficult to treat. The third thing is we have to have the right diagnosis. So treating bipolar depression is very different from treating major depression or unipolar depression. Okay, so people who have a bipolar type of depression tend to not respond as well to antidepressant drugs and tend to respond better to mood stabilizer drugs or antipsychotic drugs, sometimes along with antidepressants, but you have to have the right diagnosis and make sure that you're also treating the other comorbidities like anxiety or other things that might accompany the depression. So depression can really be helpful at the right dose, for the right amount of time, with the right drugs and the right diagnosis. There are types of psychotherapies that are very helpful. So cognitive therapy, where you teach people to recognize their depressive thoughts and how that plays into their mood state, for many people can be very helpful. There are some therapies that teach people how to manage their distress. There's a type of therapy called DBT, or dialectical behavior therapy, where people learn to recognize their signs of distress and to do some self-soothing, some mindfulness, kind of decreasing the intensity of their mood in the moment and getting some relief in that way. There's a type of therapy called interpersonal therapy, where somebody might work just on one relationship in their life, and that can really sometimes be a very powerful treatment for depression. So there are different types of psychotherapy. And then there's also, we call these neuromodulating treatments, but ECT, or electroconvulsive therapy, is something that's used pretty regularly. For those of you who haven't heard a lot about ECT or electroconvulsive therapy, it might sound kind of barbaric, but it really is a very powerful, effective treatment for patients who might not respond to other treatments. And patients who get ECT get a series of very small dose shocks to they're put to sleep, and so they have no memory of it. And they get a brief seizure, and over a series of treatments, it can be a very powerful treatment for depression when people are very stuck or very ill or aren't responding to medication or can't take medication for some reason. So these treatments are helpful, can significantly diminish the symptoms. In psychiatry, when we treat depression, by the way, our goal is 100% remission. So if people are still even a little bit depressed, they might need a little bit higher dose, they might need something added to their treatment, but we really look for 100% remission. That's not necessarily the case for anxiety, for example. You know, people who struggle with anxiety, even when they're well, struggle a little bit with anxiety. They do much, much better, but it's really hard to completely eliminate anxiety. But with depression, we have good enough treatments that we can get people 100% well and keep them well. Okay, sometimes it takes a while to get there, but there's always hope. Okay, so I want to end by just saying a few words about suicide, because that is, you know, obviously very, very devastating to families and the community and to clinicians. You know, if I've, you know, in my line of work, I've known patients who have died by suicide, and it's very, very devastating and you know, something that a lot of times a suicidal crisis is very brief, and if only, you know, 3 more days had passed or some sort of intervention, you know, it might have been life-saving. But a couple things about suicide. There are roughly almost 40,000 per year in the United States, which is about 1 every 16 minutes. And 90% of patients who have a suicide attempt or die by suicide are struggling with some sort of a psychiatric illness. And so if they could get adequate treatment for that psychiatric illness, that can sometimes get them out of the suicidal crisis. You know, many people who die by suicide haven't seen a mental health professional or even their own family physician. A lot of times people struggle in silence. Suicide is viewed as a way out of distress, a way out of hopelessness. And so, you know, when it occurs, it's very, very devastating. But I want to, you know, I think that there are a lot of things that we can do to prevent suicide, and a lot of things that we can do to pay more attention, get more people into treatment, make sure that they have access and so on to prevent that from occurring. But, you know, the good news is when people do get treatment, you know, many of them, the majority of them, do get better. Okay, so there is hope. There's light at the end of the tunnel. When I work with depressed people, I tend to use a lot of humor. I use a lot of, you know, I try to really see them as individuals, not just defined by their illness. Every person that comes in with depression is a unique, different case of depression. It's not just what you read in the textbook. It comes with an individual. And you have to look at the treatments, what's going on in their lives, what's going on in their family, what's going on at their job or school, and really look at wrapping the treatment around them, you know, from all the different angles. Okay, and I think that when we can get people involved in treatment and let them know that they're cared about and treatment is available, we have good outcomes. So, all right. So I'll end with that. Any initial questions for me before I turn this over to the rest of the panel?
Start collecting cards. If you already have questions, I can collect them while we're hearing from the panel as well too. So if you just want to pull up cards.
Okay. I'll pass this on.
Hi, my name is Donovan Most. I'm an assistant professor of psychiatry at University of Michigan. I don't really have too much to add to what Dr. Berman said. I think he gave a really nice overview of the topic. Just a couple things. So I did my residency, after medical school, I did my psychiatry residency and fellowship in geriatric psychiatry at the University of Pennsylvania. And I worked there on the inpatient unit for a year. And then came here to join faculty at Michigan last summer and work in the Turner Geriatric Center. And I'm actually also one of the attendings that provides ECT at the University of Michigan. So I think a couple things just to add about the type of patients that I see. Oftentimes with older adults, a lot of what I end up doing is really providing a lot of education. I think if probably if there are certain pockets of the population where there's more stigma around depression, I think with older adults in particular, a lot of times there's an opportunity to provide some education to help point out that it's not a character flaw, it's not a lack of willpower. It really is a biologically based illness, just like hypertension or just like diabetes. So there's a really good, oftentimes, opportunity to provide some education around that area. It does also get tricky because if a 75-year-old comes into the clinic, oftentimes the presenting complaint might be that they're having some memory trouble. And so you would really be doing a disservice to diagnose someone with something like dementia that's really an irreversible change in memory and thinking, when in fact it might be that it's depression that's not treated, and because of the depression, because the patient's anxious, because they have difficulty concentrating, they're just not processing information like they would be. So that's one of the most important things to do in clinic, is to really tease out whether you think that this is a depression or anxiety disorder versus more fundamentally a memory problem that's going on. I just will echo again what Dr. Berman said and say that we have treatments that really work. So again, there's some education around maybe what type of treatment might be most appropriate if they're not interested in medication, what would be the therapy options, what might be the best type of therapy for them. Oftentimes with older adults, they'll be on a number of other medications. So sometimes it might take several trials of medication until you find something that they don't have side effects that are bothering them or don't have sort of cause trouble with another medication that they're on. And then depending on if they've been in treatment with a number of types of medication, ECT really is a very effective treatment option, in particular for depression in older adults. And so that's really an opportunity for education because there's so much misinformation in the public about that type of treatment. So I think that was sort of all my thoughts were all that I wanted to add on to the very nice stuff that Dr. Berman already did. So I'll pass it on.
Hi, my name is Cathy Radich. I'm not an expert by any means on any of these topics, although I do have depression myself. I did just recently lose my son by suicide. He died on May 4th this year. So I'm very recently thrown into this discussion. I believe that one of the things that I think is very important for us to discuss are the stigmas of depression on young men, especially young boys. He was 19 years old and did talk to his friends about his feelings, about feeling suicidal, but he didn't want to talk to his therapist. I think one of the things that I thought about recently when my daughter was going to see a therapist to deal with some of the issues related to her brother's death, I sat in the room and I heard her talk to the woman who said to her, "Everything you say in this room will be confidential, except for two things: if you think you're going to hurt yourself or if you're going to harm someone else." And that really hit me because I sat there and I thought about my 19-year-old boy hearing that. And I think he would have heard that and that would have been the end of the sentence. And then they would have gone and had their discussions and talked about several things. But what he would have heard at that point is, those are the two things I'm not telling this person, because that means I'm crazy. That means I've reached a point at which there's maybe no help for me. And it's scary. It's scary to think about, well, then what comes next? Does that mean I will be thrown into a funny farm? Does that mean I will no longer have the liberty to have freedom to go out with my friends and do things because now I will be looked at differently, or I'm going to need to be looked after every day and taken care of? I think it might have really scared him. So I do think about that a lot and think about what people can say. If you're a therapist, what you can say to say, this is what we'll have to do if you are feeling this way, and not just leave it at that one last sentence. So I think that's something important we should discuss today. Thanks.
Hello, that's pretty loud. I'm Joel Bennigan. I'm the school social worker here. I'm at the 4-5 building. And they told me I was just going to answer questions. So the doctor changed the format of the panel, so I wanted to let you guys know that before I spoke. We see a lot of sad kids, even at the age of, or the grades of 4 and 5. So we have 840 students in my building. I guess what I would say here to parents and to students is if you have a child or one of your peers that is sad or you're concerned about them, to let the mental health staff, the counselor, or the social worker at the school know so that we can talk to that child. And we will make it our first, and that's my top priority. If I'm worried about somebody's safety or I think they need to be talked to, I'm going to drop everything and go talk to the student. So we like to see kids, we want them to be happy, but if we don't know about it, it's harder to do. And we work pretty hard to reduce the stigma of getting help at the school. Kids like to come in, and I think that's a goal district-wide to improve in that area. Just encourage your child or your peers if they're worried about someone to let us know, because that's the best approach for getting help. I think when some students come on their own, and we're fine with that. Thank you.
Okay, there are some questions and we can sort of, I think a lot of these are sort of geared toward the providers, but if there are some for the social worker or for Cathy, feel free to write those, because we don't want to be the only ones that talk.
You can give them to the medical guys.
Yeah, well, okay. I did want to, and I'm going to stand up. I don't like to sit down. I did want to comment about the confidentiality and the stigma that young men feel. And I think it's, when I talk to young people, I have to be honest with them and let them know that, everything they share with me is private and I don't have any reason, or by law I can't tell their parents the things we talk about. But I try to say to them that, I care about you and I want to protect you, I want to keep you safe. And so if I have any immediate concerns, if you tell me you're going to go home and kill yourself, I don't want to see that happen, and I would try, really try to help you and find a way for you to be able to tell your parents or let us know that you want to get the help you need, or even talk about whether you need to be in the hospital or someplace to keep yourself safe. But short of an absolute threat to safety, the person is saying, I'm going out to kill myself, I try to let patients know that it's safe to talk about suicide, because there are degrees of suicidality and degrees of safety risk, and we try to assess that every step of the way. So just because somebody has suicidal thoughts doesn't necessarily place them in immediate danger of being suicidal. So somebody might say, I'd be better off if I weren't around, but oh my gosh, I would never do that, and what came over me, and it passes. Somebody might actually think, this is a legitimate way of escaping, but I would never do it, I couldn't do that to my family, and they can do some safety planning and sort of align with you and keeping themselves safe. And I wouldn't necessarily have to tell somebody else about those thoughts. On the other hand, there are people who are actually planning, I have a bottle of pills at home, or I have a gun in my home, and I really think I might try to kill myself. First and foremost would be safety. And so I try to explain, especially to the young kids I work with, that, short of immediate danger, we can still keep some of these discussions confidential. But if I really feel like it's crossed a threshold and we need to let your parents know something, let's find a way to tell them and bring them on board. And it doesn't mean you're going to be stuck in a hospital. It's okay. There are a lot of people with depression who are suicidal and out walking around and having jobs, and they're in treatment and they're discussing it, and they can be safe, okay? So it doesn't necessarily mean you're going to be stuck in the hospital. We can do that if we need to, but not necessarily, okay? And I say the same thing about substance abuse and other kinds of things. There's a degree of risk that you have to make known, but other stuff you can keep between you and your patient. I would say to the general public, however, if you're concerned about somebody being suicidal, you should not keep it a secret. So, if you're a student, for example, in school, and one of your classmates tells you they're suicidal, tell an adult, tell your parents, tell somebody, okay, so they can get connected with help. Our policy for privacy and confidentiality is a little bit different as providers, as physicians. We have a little bit more leeway with that, but, you know, as a member of the general public, if you're worried about somebody's safety, let somebody know so they can get the help they need, okay? I don't know if you had any comments about the privacy. Okay. So some of the questions. Once someone has been diagnosed with depression and are 100% in remission, do they still carry the diagnosis of depression? That's a good question. So basically what I would say in their medical record is depression, comma, in remission. So that, you know, I do consider depression a chronic illness and it can come back. I might say in remission. And just to say that they're doing well and they're better, okay? And that can sometimes drop off of their record if they go to a different doctor and they're dealing with, you know, another issue. Their primary care doctor might not have that in the record or something. I think it's important for people to know. And the way I look at it is, since there's nothing to be ashamed of, I mean, it's part of your medical record, just like the broken leg you had in 4th grade. And the time you had surgery, got your appendix out. You know, those are all parts of our medical record that stick with us, and that's okay. That's the way I look at it. What are your thoughts on antidepressants and or anti-anxiety medications in young children when coupled with therapy? So, how young are we talking? Like school-age kids?
Like 5.
Okay, 5-year-olds? Okay. So, 5-year-olds do get depressed, okay? I mean, and it's more rare. So kids at that age tend to be more resilient. So, you know, they might be depressed for a day and then the next day they're fine. Okay, so they don't tend to have the same kind of major depression with the biologic kinds of symptoms and and a lot of times when a kid that young is depressed, there may be something going on in their life, some sort of a stressor, you know, parents are getting divorced or something's going on in the home or whatever. So we do use medications in that age group, but it's more rare. So if I'm treating a kid that young, I really want to be sure that they have the kind of depression that needs medication. I would much more likely refer them for therapy, get them with a play therapist that they can, you know, play and let some of the themes about their depression come up in therapy, and also work with their parents to kind of recognize and help the child cope in healthier ways. But that's not to say that we don't use medications in that age group at lower doses. I try to avoid medicines that can have abuse potential or addiction potential for a couple of reasons. I don't want to put a 5-year-old on Xanax, okay? I would never put a kid that young on something like that. With the exception of a kid who has like a phobia of the dentist or something, and you know they kick and scream and cry and can't get in the dental chair, I might give them a little bit of a sedative, but not generally to treat anxiety. And I also take the risk in a kid that young that the medicine I give them would fall into somebody else's hands. That happens. So, I have to keep my eyes and ears open and have my radar up for that. Okay. How do you deal with patients, especially children, who are apathetic toward treating their depression? You mean every teenager I see? Okay. They are, you know. I try to recognize that and validate it and say, you know, look, Billy, I know your mother dragged you in here, you know, on a Friday afternoon at 4 o'clock. You would not choose to be in my office. I know that, you know, so what can we do to help you cope with that? What can we do to kind of deal with this? I really try my best to try to align with the person. Let them know it's okay to be apathetic. You know, I talked with a young lady yesterday who is an active substance abuser. She's a teenager. She smokes weed every day. She said, look, Dr. Berman, I'm not sure I want to quit. I'm going to be honest with you. It works for me. I enjoy getting high. Yes, I'm depressed. I don't want to give it up. I can't promise you I'm going to try to give this up. You know, so my response to that is, I appreciate you being honest. You know, I think your life would be a lot better if you got treatment, gave this up. I've seen lots and lots of people get better, and help is available. We have a great group here that meets on Thursday afternoons. I really think you'd do great in it. Just know that it's available for you. And let me know if you're thinking about this changes, you know, and I might do a brief like pro and con list with them, but I don't insist that they do something just because I say they do it or their parents say. I really try to align them, and motivation can change over time, okay? There's a type of interviewing we do called motivational interviewing, where it's called rolling with resistance, where you know, the person is resisting the treatment, and you say, that's okay, you know, you don't have to get better this week, you know, we'll meet next week and whatever, you know, it's okay. You know, so I let them sort of take the lead and give me some guidance on that. Do you want to make a comment about geriatric patients who might not believe they're depressed or be motivated?
So, excuse me. I think there are definitely some parallels with the geriatric population, like in child and adolescent, because oftentimes the patients that I see are there because their kids brought them or their spouse brought them, and so there can be an interesting dynamic, especially when it's a patient with their kids. Sometimes the patients aren't so happy at sort of feeling like their kids are telling them what to do, so it can be a little bit of a generational role switch a little bit. Usually though, people, oftentimes if they are there with their family matters a lot to them, and they're very sensitive to the idea that their role has changed in their family. They're not really taking pleasure and joy out of being with their family in the way that maybe they used to be with their family. Oftentimes if the families have brought them in, the families are very supportive and they just really want what's best for their loved one. And generally, patients are willing to try. They really want to feel better. They want to do what's best for them, and they also a lot of times want to please their family, please their spouse, and please their kids. And so then it's just will be sort of education around the treatment, kind of normalizing the treatment. Oftentimes I see people who are on medication for blood pressure, so it's really just equating this antidepressant in some ways it's treating a chronic condition, just like your blood pressure is a chronic condition, and you don't really have any trouble taking your metoprolol, and so the Zoloft really is kind of the same thing. Essentially, it's just something we're trying to do to help you feel better. And usually they're willing to go along with it.
I'm gonna let you answer the question.
Oh, okay. So I had one question, and it is, what kinds of practices or communications from therapists do you think would better benefit teens who may be considering suicide? So I've thought a lot about this, obviously, and there are several things that I've thought about. One is if therapists could use social media or texting with their patients who might be teens, since they tend to really go that route. Kids are always on their little, iPhones and electronics. I think that one of the things I noticed with my son was that he was willing to talk through text. He sent many texts to his friends, and the friends got those and reacted to them. When his device was dead, out of power, he had only his mind to be thinking about how he was feeling and ruminating those thoughts. So I think if therapists could use, and I've seen it being at the University of Michigan as well, I've seen us use texting to get people to answer depression questionnaires, small ones, simple ones that maybe are 4 or 5 questions, maybe to Beck, to just assess at certain time points how somebody's doing. And I think that might be one thing that could work for teens. I think the other big thing that I would like to see happen more is that my son did talk very much to his friends. And like you said earlier, get to an adult or someone. And I know my son was 19, he was an adult, right? But he was a 19-year-old adult, and he was talking with other 18, 19, 20, 21-year-olds about how he was feeling. And they were doing what they thought was helping at the time. And it was helping at the time. But you can't be with somebody 100% of the time. So it really was about making sure that if you have somebody who's talking to you about thoughts of suicide, that you do take it to the next level. Call 911, do something, get them some professional help, because even some of the texts that said, call your sister, call your mom, even I would have to rush there and still not know what to do necessarily. So it's not a disease that needs to be handled by a child or by a young adult. It's something that you can be with them, but get them professional help, get them professional support, because you can be with them until they can get to somebody who can actually help them more.
I like hearing those suggestions because it helps me think about how I practice and some of them. The thing about the media, it's a little bit tricky because there's some legal ramifications. And for example, in a big organization like the University of Michigan, they actually prefer that we don't communicate with email and let alone texting. And we do it all through our medical record system, so it leaves a trail. Now that said, I hope I don't get in trouble, but I have some of my teenage patients that'll like, hey, Dr. B, can you fit me in at 2 o'clock next weekend? Sometimes I don't give everybody my cell phone number, but people that I've worked with a long time and know very well, I think you have to use discretion. So that's my take on that.
The question I have here is, and I'm sure the other folks on the panel can also speak to this problem. I'll give my 2 sentences. Can you give examples of language young people might use to indicate they are suicidal, other than I feel suicidal or I want to commit suicide? So that's a good question. And the doctor spoke about a lot of the signs we see with young kids when maybe they're not going to say they're lethargic, they don't want to come to school, have a suppressed appetite, and they just present as unhappy. But a lot of things, I'll ask the student, what are you looking forward to? And if the student can't share with me anything they're looking forward to, I get pretty concerned. Or, what do you want on your next? I work with a lot of young kids. I work with adolescents and adults, but currently pretty much 10 to 12-year-olds. They say, hey, what do you want for your birthday? If they can't come up with anything, that's disconcerting, because, that's a sign that something is awry, because everyone's wanting something for their birthday. Let's see if I think it's, hopelessness is also, if a student says, I feel worthless, I'm hopeless, I don't have any friends, also signs of, that are disconcerting, particularly hopelessness. Thanks.
I would say one would be, I'm scared for my future. I think that was one thing I think that I heard that I think was powerful in retrospect now, that my son was scared about his future and what it would look like.
I ask them directly, okay? As a professional, I ask it head on, and this is something I have to, teach the medical students I work with, and so a lot of times people will sort of drop hints about what's going on, and when they're coming to my office and they're coming to be assessed for depression, when they say, I don't know what I'm looking forward to and I'm scared about my future, I say, have you been so scared and so overwhelmed that you can't see a future? Have you thought about dying? Have you thought about killing yourself? How bad has this gotten for you? And when you do it in a very matter-of-fact way, it can often make the person much more comfortable, and it's like, oh, thank God somebody's asking, and it's okay. This is normal. It's part of many people with depression struggle with these thoughts. With little kids, I might say something like, have you been so mad or so scared that you didn't think you wanted to be alive anymore? That scared? That mad? And a kid who's not suicidal will say, no, not like that. But if a kid agrees or says yes, then you have more of a discussion. I'm a professional who deals with this all day, every day, so I'm not suggesting that every person who's sad, you ask about suicide. But if you really are worried about somebody, and they're dropping hints, it is okay to ask them directly. I'm really worried about you. Are you thinking about suicide? Are you, thinking you want to hurt yourself or kill yourself? It's scaring me when you say those things. Oftentimes that'll be open the door for the person to talk more about it. Okay, you don't have to be scared to ask. You're not going to plant the idea in their head. Okay, I've never met somebody who wasn't thinking about suicide. Somebody asked them about suicide, and then they started thinking about suicide. Okay? It's only, they're already thinking about suicide. Nobody asked them directly, and so they were afraid to talk about it. That's much more common. Okay?
That's universally the response that I would get if I ask someone if you thought about hurting yourself. They're going to say yes and go on and share it with me, or they'll look at me like, "Why are you asking me that question?"
And I would say, I don't ask, have you thought about hurting yourself? If I do, I also say, have you thought about suicide? Because, especially with teenagers, a lot of times they do self-injurious things like cutting and burning and a lot of self-injury when they're really feeling crappy. And so I was sitting in the room with a patient, and the medical student was there. We always give them the chance to interview them first. And the medical student said to the patient, have you had any thoughts about hurting yourself here in the hospital? And the girl said, no, I'm fine. And then I said to the patient, what about thoughts about suicide? Well, yeah, that's why I'm here in the hospital. And, last night I was thinking about it and so there's a difference between have you thought about hurting yourself and have you thought about dying or suicide? Okay, and that's an important distinction for somebody like me, especially with the age group I work with, to make that distinction and to ask directly. Okay, just a couple last questions. How do you deal with patients, or what is the next step after a patient does not respond to ECT? Okay, so it might seem like it's hopeless and they're not going to get better. ECT is not the end of the line treatment. It is a treatment. Many, many patients respond to it. Some types of depression are not as likely to respond to ECT. So, I talked about that dysthymic kind of depression, or, a depression that might be comorbid with another illness. It might not respond as well to ECT, so we simply choose other treatments. More therapy. The other thing, sometimes patients who get ECT who don't have a complete response will then respond to medication, and the medicines will work in a different way afterward. And I'll see if you have any comments about that.
Yeah, so oftentimes there are several good but old classes of medication that don't get used very frequently anymore. So like the tricyclic antidepressants, or MAOIs is the name of another family of medicine. So oftentimes there are whole families of medicines or many individual medications that people haven't tried. It might be that the type of ECT that they had, whether it was bilateral ECT or unilateral, it might actually be that they tried one but not the other one. And also, people in some ways need to, I'm usually not in the business of telling people to find a new therapist, but just the way that you think about trying an alternative medication. Sometimes if the patient's been working with a therapist for a long time, maybe it's just not a right fit, or it's not the right approach. So oftentimes there are many other different parts of the treatment that could be modified or could be changed. So basically there's always another option.
Yeah, and that's important. And we do an ECT sometimes in teenagers as well. So I tell them, this is not the last ditch treatment. So don't think if this doesn't go well, there's no hope. There's always hope and always other things we can do. Okay, so that's very, very important for people to remember. Do recurrences of depression become harder to cure? They can. So depression that it tends to be recurrent. The most important thing to remember is if depression keeps coming back, stay on the medication. Okay, so once you find something that works for you, so if somebody has like a single depression, they go off to college, they start their freshman year, they get depressed, come in, put them on an antidepressant, and they get better. It's reasonable to have a trial off of that medication, maybe a year later or sometime later. If the depression keeps coming back whenever the person goes off their medication, stay on the medication. That's really important. And these medicines used over time, chronically, we don't know of any kind of negative effects on the brain or anything about the person from these medications. They tend to work on the normal neurotransmitters and brain chemistry that we already have. They make it work in a little bit different way. But the medications don't have any long-term dangerous effects, but untreated depression can. So when those episodes keep coming back, they might get more severe and more treatment resistant. So once you get well, stay well. And only make any changes in medication with your doctor's directions and their approval, okay? So you don't want to be going on and off the medication. What are the top 5 things to look for in an individual who may have fallen into depression? So I would say, I'm not going to list necessarily 5, but I say look for a change. Okay, something is different. Trust your gut. So the person isn't themselves. They're not hanging out with the family as much. They're more mopey. They seem like they're, out of it, or and sometimes you just ask, how you doing, and they say, I'm sleepy and I haven't been getting enough sleep, and that's fine. But you don't want to miss a depression. So look for a change. Something is different, something that you sense that they're not themselves. Okay? It might be something very simple, or it could be depression, and it's okay to ask. Okay? Also look for changes, for parents, look for changes in sleep or appetite. Your child is having difficulty sleeping, not eating as much, something may be going on physical with that person. Okay. If I suspect my child has depression, who do I call first? One thing I recommend is to start with your primary care doctor. So if you have a pediatrician that you work with or a family practitioner, you might give them a call. And I would start with getting like a good physical exam and have them come in and talk to their primary care doctor. Because kids do get moody. Sometimes it's just a normal part of their development and it's pretty typical. And pediatricians, oftentimes have their finger on the pulse of that, and they're generally pretty good about letting you know, I think there may be something else going on. Let me give you the number of some therapists in the community, or let me give you the number of a psychiatrist I know, okay? So start with primary care. The other thing, talk to the teachers at school and get a history from them and say, I noticed my kid's kind of mopey, something's wrong at home. Have you noticed anything at school? Is there anything going on? How are they doing in the classroom? How are their friendships? Kids spend 8 hours of their day at school, right? So that it's a good laboratory to kind of see how they're doing. So a call to the teacher or school counselor can sometimes be really helpful. And then the question, what exactly is bipolar? How does it manifest? What is manic depression? And how does it tie into bipolar? They're one and the same. So bipolar disorder is manic depression. Manic depression is an older term that was more popular in the 70s and 80s. But the official diagnostic term for manic depression is bipolar disorder. And like I was saying earlier when I talked about the types of depression, in order to give somebody a diagnosis of bipolar disorder, you really need to see a manic episode where they're not just in a good mood because they're feeling better, but it's better than good. There's a change in the other direction. The person is maybe very, very unusually talkative, kind of slap happy, acting silly, kind of reckless, doing things that are out of the norm for them, okay? Because manic states can be very, very severe, just as severe as depression. People get hospitalized not infrequently for a manic episode. They can begin to have psychotic symptoms, lose touch with reality, okay? So that's the most extreme kind of manic state, but there are more milder forms of mania as well. But the key is to get that bipolar diagnosis, you have to have at least one episode of a manic state, okay? Now, having said that, if somebody only has a manic state, so the first time they come to attention at the emergency room or the hospital is they're in a manic state and they've never been depressed in their life, that's still bipolar disorder. Okay? Once you're manic, you have bipolar disorder. Okay? Just because you're depressed doesn't mean you have bipolar disorder. You have to have that mania. Okay? Is that clear? Does that make sense?
Do you want to speak to the differentiating with adults and children for bipolar?
Yeah, sure. That's a good point. So how do you differentiate between children and adults? Kids tend to be just more moody at baseline. Their moods flop all over the place. So especially during adolescence, when you have so much going on, kids are struggling with identity issues and who they are, who their friends are, what they want to be when they grow up, who likes them, who doesn't. They have their first crush. And then kids also at that time, a lot of times kids are struggling with things like sexual orientation or questions about themselves and a lot of different things. So it's a very tumultuous time. And so their moods can be all over the place. Okay? That by itself doesn't make somebody bipolar. You still want to see a distinct change or an episode that is a deviation from the norm. Okay? Now in kids, those episodes can come a lot more frequently. Okay? And sometimes you don't see the classic manic episode that's so bad the person has to be in the hospital. Okay? But you can still give a diagnosis in bipolar. I think we're still learning a lot about what bipolar disorder looks like in kids. There are probably a lot of kids who are diagnosed with bipolar that don't end up being an adult bipolar. They sort of outgrow it. And maybe it wasn't bipolar after all. There are just as many kids who we think have attention deficit or some other behavior problems or unipolar depression who turn out to have bipolar disorder. Okay, so you have to look at things like the family history and that sort of thing too. They can all sort of lend evidence to that. I'm confused about FDA approval for antidepressants in children. I know Prozac is the only approved medication in children, yet I know kids use other medications. Can you elaborate on this topic? That's a really good question. A lot of our prescribing in children and adolescents is what we call off-label. So in order to get an official FDA approval for a medication, there's a lot of steps that have to go into that, a lot of research, a lot of money, and it's oftentimes difficult for the pharmaceutical companies or the people who make the medications to conduct the studies necessary to get an official FDA approval. So really what we base our treatment choices on are other types of data that are out there. So there are studies on these medications, and there's good data to show that they're efficacious and work well, okay? But that doesn't necessarily mean that there's FDA approval for the medication, okay? And there's also another medication called Lexapro, by the way, that is FDA approved in teenagers, okay? But other antidepressants aren't necessarily approved, but we use them anyway. I think it's more dangerous to not treat the depression than to use a medication that might really be helpful. Okay. Are other people getting questions?
I just got one. It's long ago.
Yeah, so one question is, what can you expect a complete response to look like? So I really depend on what the patient and their family say about what the patient looked like, since oftentimes when I meet them, they're depressed. So I'm actually not really sure what they looked like when they weren't depressed. There are the symptoms that we use to make the diagnosis of depression. So if they're not sleeping well, if they're not eating, if they've lost weight, you want to see those things improve. If they have stopped gardening or mowing the lawn or the different types of hobbies and activities that they used to pursue, you'd like to see them start doing those things again. If they maybe withdrew socially and weren't seeing their family as much, or maybe their kids or grandkids, it was hard for them to be around them over Thanksgiving because it was overwhelming and too much stimulation. You want them to get back to the place where they could really enjoy that. So you basically want their function, their role to go back to normal, to what it was like before the depression started. And so a lot of times in the first appointment, I'll say, when's the last time that you felt like you weren't depressed? And well, so if I had met you then, what would you have looked like? What would have been different? And so those things that they say were different are really what we want to see come back if it's a successful and complete treatment. Anybody else have any thoughts on that?
I just want to say one thing. In teenagers, I have parents that say, "My child had a fight with me this afternoon. They're back to their old self." Because they talk back and they gave me a hard time about the car keys. They're better, and sometimes that's true, So it's like back to their old functioning, good or bad. Okay, especially with teenagers because they like to do battle with everybody.
So then, what about the argument that antidepressants can cause suicidal thoughts? So I'll start, I guess, as Dr. Berman might have some thoughts on this one as well. So in general, that's more of an issue actually with the younger population. So there's some idea that when people respond to treatment for depression, this seems to be both the case for medication treatment and oftentimes with ECT. A lot of times the provider and family members will actually sort of notice that the person's doing better, while it seems like sometimes kind of internally they don't necessarily feel like they're doing a lot better, even though the people around them, it seems like this person is really feeling better. So sometimes it seems as if the person's energy level is starting to pick up before sort of how they're thinking, before their mood has really caught up with that energy level. So you could think that there's maybe this little period of time where they're still feeling bad about themselves and their mood is not very good, but they have a little bit more energy and they're a little bit more activated. And so you could see how maybe that might be a period of time that could be a little bit uncomfortable, and where maybe if they had been having thoughts of self-harm or suicide before, but they were just so tired and it was like too much to think about, where maybe their energies picked up a little bit more, and so, but some of the negative thoughts are still there. So the warning around antidepressants really is around ideation or these types of thoughts. It's not actually about attempts, actual suicide. So that, I would say, is a very important thing to keep in mind. So as a provider, I essentially it's something that I'll prepare patients for, that there might be this period of time where they feel a little bit more activated, and to keep an eye on, but it's certainly not a reason that I would not prescribe something, because we know 100% that untreated depression is a risk for suicide.
Yeah, I would echo that. The data, honestly, on suicidality and antidepressants is very weak. Okay, there was a study done, it was done in Great Britain with a medication called paroxetine or Paxil, and they gave the medication to a group of depressed teenagers, and there were about 400 kids in the study. 200 of them got a sugar pill, and 200 of them got the actual medication. And that's how a lot of research is done, and then you compare the groups and see whether the medication is actually working. In the group that actually got the medication, there was a slight increase in what they called spontaneous reporting of suicidal thinking. Okay, so some of them, those kids talked about suicide. It was about 4%. Okay, so not a lot. None of them killed themselves, none of them hurt themselves. They just sort of spontaneously reported. In the kids that got the sugar pill, about 2% of them spontaneously reported that they had suicidal thoughts. Not a lot. So when you compare 4% to 2% with 400 people, that's enough to be significant when you actually do the statistics. And so, black box warning, antidepressants make you suicidal. What happened after that was a lot of primary care doctors in the United States stopped prescribing antidepressants to kids with depression. They just weren't comfortable with it and didn't really, understand the real data and how little data there was. And for the first time in about 20 years, we saw a spike in suicides in adolescents because fewer of them were getting treatment. So what I always tell parents is, if it were me, if it were my child, and you're really worried about the risk of suicide, treat the depression. Because untreated depression is much more likely to lead to suicide than treated depression. We can handle that early stage where they're still feeling depressed and have more energy. We can carefully monitor and watch, but don't leave it untreated. Okay.
I think there's another a long question. I'll read. Do coaches, teachers receive any education about stress reduction? Any courses and services to help them make treatment, talk about depression more common in their interaction with kids they work with? They talk about sports nutrition and strength training and injury prevention, but not mental health. That's a good question. I'm not at the high school, so I can speak more, I think, intelligently about the building I'm at, which is the 4-5 building. I think it's safe. At the high school, they have health courses where they do talk about, I think, mental health continuum. At my building, we have an in-service where I talk to the staff about what to do if they're worried about the safety of a student, be it safety for themselves or safety for other students. So suicidal ideation or homicidal ideation, and also what to do if we're worried about child protective services, child's being hurt. So we do cover that. I'm relatively certain it's about similar discussion occurs at all the buildings. And then district-wide now we're working on improving our the way we communicate about mental health services to parents. And just our biggest, one of the things we want to do is try and reach the most parents we can, and finding the times when parents are most likely to be at the school to come and listen to us talk about this, so we want to find maybe when they're picking up their schedules or when we can reach the largest amount of parents to share about mental health issues. So, thank you.
I would actually like to see schools do more of that, because I think the more of an open dialogue, the more we teach about it, the better. And parents get nervous and school officials get nervous. I think they're afraid that if you sort of raise these issues, more kids might come forward, or it might sort of cause them to get depressed. Or what do you do when you find a kid who's really suicidal? We've got to do something. So there is some resistance and some, but I think, we have to talk about these issues, and we've got to talk to kids about, safe sex and drugs and mental health issues and suicide and all those things that they really do deal with, that we can't just brush under the carpet. But it is uncomfortable, and I think we recognize that. But I think getting some help from people who are comfortable with these issues and can kind of address it in a very professional, matter-of-fact way can be helpful.
In our district, we have a protocol for students who are.
Yeah.
So we try and be proactive about that.
Just a couple real quick ones. How does depression relate to anger or aggression toward others, and vice versa? There's not necessarily a link. So somebody who's prone to depression, they might be very irritable, on edge, and so somebody who's prone to aggression, if they're feeling that way, they might be more likely to exercise that aggression or demonstrate it. But depression by itself doesn't cause people to become aggressive. Neither does more serious forms of mental illness like schizophrenia and that sort of thing. We hear in the media those cases about the person with mental illness that, there are always incidents like that, but there are even more where the person is not mentally ill, and so there's not necessarily a link. And then here's a question from somebody, for somebody who is in treatment, how does the family best support the patient when the patient slips into a depressive state? So. And this is a very good question. I get this a lot from family members and loved ones. And I tell them to be, supportive and a careful observer, but to not hover. Okay, so people hate it when somebody is like, oh my God, are you depressed? You had your therapy appointment yesterday and you're sad today and I'm really worried. Those types of reactions can discourage the person from talking about it. So the biggest reason kids will say they don't want to talk to their parents is they're afraid they'll overreact. I can't tell them I'm having a bad day because they're going to think I'm not taking my medication, I'm really depressed. Can't I just have a bad day and have it be okay? So the answer, of course, is yes. So as family members, it's okay to say, are you feeling okay? Things all right? Would you let me know if they weren't? I'm here for you. Anything I can do to be supportive, and leave it at that, and just let them know you're available. Because sometimes probing too much, can sort of make the person withdraw. There's something called expressed emotion. And in families where there's a lot of, oh my gosh, are you okay? I'm worried about you. Or even like blaming. You're using your depression as an excuse. You're just lazy, you don't want to take out the trash. So you're moping around. Don't use that depression against me, So those kinds of messages obviously are not helpful. And patients who don't have a good recovery environment, a supportive recovery environment, don't do as well. So just being supportive, encouraging. And what I say to people who are depressed is, if you want your family members off your back, let them know you're okay. So you don't only have to go to them when you're depressed. You can get up in the morning and say, things are going well, I'm feeling good today, no need to check in. Or sometimes I'll suggest to parents, have a 10-minute period during the day. Your kid hates it when you talk to them. You hate it when your kid won't talk to you. So you have that 10 minutes a day where you get to ask every question you want. But when the timer stops, you're done. So prioritize those questions. Get the most important ones out first, because you've got to give your kid a reprieve after that 10 minutes. And you say to the kid, during that 10 minutes, as much as it drives you nuts, you've got to answer your parents' questions. Let them know how you're doing. Let them know whether you have homework. Don't roll your eyes at them or stomp off. Answer the questions, and when the timer goes off, you're free, okay? So sometimes a system like that, can really be helpful, okay? But it's important to talk about, you can ask the person, how do you want me to, I love you, I'm concerned about you. You get so irritated at me when I ask you about your depression. How do you want me to approach this? Give me some guidance and some feedback, okay? And that can sometimes be helpful.
Cathy, could you speak a little bit about your experience about what was helpful in your family?
In our family, so I have depression, and I can tell you I would get very irritated if my husband was hovering and asking me all the time how I'm doing. So I do think it is helpful to have that conversation up front and say, please don't ask me every day how I'm doing. Don't pressure me into, always looking like I'm happy or not being happy. But do challenge me a little bit, because not that I want to use my depression as a crutch, but there are times where I just won't go out and do something if I am feeling depressed. And so to challenge me and say, is it because you really don't want to do this activity, or is it something you would normally want to do, but you just can't get the energy to go do it? And I know sometimes it is just the depression, and I will make myself go do something. So I think it is important to have that conversation and be open about it.
Mm-hmm. Don't take it personally if they don't want to do something with you. I tell people to be kind of gently insistent. Mm-hmm. Come on, we're going to the movies. I don't care what you say. I'm going to give you a noogie. You're coming. And, and they'll really let you know, like, look, by God, I'm not doing this. But sometimes just that little extra nudge, a sense of humor, just kind of, I'll miss you if you don't go with me. That those kinds of messages can be helpful.
Yeah, I maybe the word nudging is good. So I had a patient who just was spending too much time in his bedroom, and they had the blackout curtains in the bedroom, and so I said to the wife, just take the blackout curtains down. So just make it a little nudging. So it's maybe the routine, the depressed routine is a little bit less comfortable, I guess.
All right, well, thank you very much to our panelists. I also want to thank Saline Alive for hosting today. Did you want to say something? No. Okay. Well, and thank you to all of you for your time and for your questions. I think our panelists will stick around for a couple minutes while we're leaving. But if you would also fill out those evaluations, we